We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I'm your host and moderator, Dr. Lauren Levine. We got a great webinar tonight, and we actually set a record. So as of this morning, we had almost 1,200 people registered for the webinar, and a lot of you are here and logging in. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Kosinski can speak for as long as he needs. We want to make sure that we leave some time at the end for questions. Now, with a group this large, I'll be upfront. We're not going to be able to get to every single question, but I'm going to certainly do my best to try to answer as many as possible. Most of you have been on webinars in the past. You know how it works. You have a control panel on your screen. Just go ahead and type in your questions as you think about them. We don't normally get to the questions until the end of the presentation, but I will try to get them in the order that we receive them. In the next few days, you are going to receive a few things. This webinar, like all webinars, is being recorded. So if for some reason you can't stay until the end or you get distracted, don't worry about it. We are recording everything, the audio and the visual. That normally goes out sometime within the next day or two. I wanted to absolutely thank GoldenDent for their sponsorship of these webinars. These webinars are not easy to put together. We need help and assistance. GoldenDent has been great on doing this. This is an ongoing series of webinars that they've provided. If you've been in dentistry, then you know that GoldenDent is committed to dental education, and I want to thank them for that sponsorship. As part of that, if you are attending live, we can't do this if you're just watching the recording, but if you're here now, you will receive a CE certificate. GoldenDent handles that. Give them some time, please, because when we have 1,000 people registered, it takes some time for all that stuff to go out. So without further ado, I want to introduce tonight's speaker, and that's Dr. Tim Kosinski. And if you've been on past webinars, you've heard Tim speak before. Tim is excellent. He is an adjunct assistant professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial review board of Reality, which is the information source for aesthetic dentistry, contemporary aesthetics, and clinical advisors. He became the editor of the Michigan Academy of General Dentistry. He got his DDS from University of Detroit Mercy Dental School and his mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology, the International Congress of Oral Implantologists, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry. He got his mastership in the Academy of General Dentistry. He's received many honors, including fellowship in the American and International College of Dentists and Academy of Dentistry International. He's a member of OKU and the Pierre Fouchard Academy. I won the Pierre Fouchard Award when I was in dental school. I still don't know what it was for, but maybe he does. He was the University of Detroit School of Dentistry, Mercy School of Dentistry Alumni Association Alumni of the Year in 2009. He received the Academy of General Dentistry's Lifelong Learning and Service Recognition. He has published dozens and dozens and dozens of articles on surgical and prosthetic phases of implant dentistry. He's been a contributor to textbooks like The Principles and Practices of Implant Dentistry and Dental Implantation and Technology. He was also featured in Noble Biocare's Noble Vision, and he lectures extensively. So with that introduction out of the way, Tim, we're looking forward to tonight's presentation. Take it away.
Hey, Lauren. Good evening, everybody. Hopefully we'll have a good hour together. Lauren, I really, truly appreciate the invitation. I always enjoy these programs and sharing the information with your listeners. Well, today's topic I think is very, very important for the general dentists, general practitioners out there. And we called it predictable grafting for any experience level and any patient budget following atraumatic extraction. And where your course objectives tonight are quite simply, we're going to review some of my atraumatic extraction techniques. Many of you are aware that I'm a big user of the GoldenDent Physics Forceps. I would not practice without it. I think it's a very important tool that we'll discuss in pretty significant detail throughout the program tonight. We're gonna do some step-by-step instructions on how to immediately implement simple socket grafting procedures that's both affordable for us, meaning that it's not costing us a lot, and for the patient. I think we all know that when we remove a tooth, bone is going to shrink, and it's going to shrink down and in or up and in. Sinuses are going to collapse. And with the advent of implant dentistry being so popular today, it's imperative that as we remove teeth, we try to maintain the quantity of that hard tissue so that we can place implants either immediately or in the future. I think this is a very, very important tool. Now, many of us out there will say, well, our patients don't want it, or dental insurance doesn't necessarily cover it. And I think that at the end of our hour together today, I think you'll clearly see that this is a treatment modality that is both affordable for the dentist and for the patient, because not only does it help maintain the hard tissue level, but it also provides us an outstanding site for our more profitable dental implant procedures. We're going to talk about the different graft materials. Now, obviously, there are hundreds of materials out there, and I'm not going to discuss all of them. And I think in fairness, what I'm going to demonstrate tonight is what works very well in my practice. We place over 1,000 implants a year in our practice in the Detroit area. And we do a lot of grafting procedures just about every day. I'm going to show you what works in my hands and the protocol and techniques that work in my hands. And I like to say in my lectures that we can grow bone 100% of the time. We just have to follow the recipe and follow the proper protocol and techniques. And I'm going to share those with you briefly today. Again, grafting is very, very important, and it's important that you be able to comfortably explain that to your patients. Explaining that if they don't have grafting procedures done, they may lose so much hard tissue that placing implants in the future may be prohibitive, or may require a much more invasive surgical procedure and a much more expensive surgical procedure. We'll talk about suturing a little bit. We'll talk about reflection or flap design and the use of membranes. Membranes are barriers or band-aids that help protect whatever graft material we use from invagination of epithelium. So, very briefly, let's just go through the hard part of the program, and then we'll get right into a clinical. All skeletal bone demonstrates volume stability over time, except, of course, what we're working with, the dental alveolar bone. The dental alveolus is very labile in the absence of loading. What does that mean? We all understand that clinically, right? When you remove patients' teeth, bone will shrink. Patients that wear dentures have to have relines periodically. For those of us who are not placing dental implants routinely in your practice, you're not, from what I understand from my courses that I give, is you're afraid of the inferior alveolar, the mandibular canal, the mandibular nerve, and the sinus area. And we're concerned because there's bone loss in those areas, which makes simple implant placement more prohibitive. But bone grafting is possible because bone, unlike any other tissue in the body, can regenerate completely if provided the space to which to grow. As native grow bones, it generally replaces the graft material completely, resulting in a fully integrated region of bone. The biologic mechanisms of this are called three different things: osteoconduction, osteoinduction, and osteogenesis. So the mechanisms of bone regeneration: osteogenesis is the ability to create viable bone cell development. This is when we use the patient's own bone. We can take bone from the symphysis or from the ramus, or we can harvest bone actually from our osteotomy sites as we're drilling our openings for our dental implant. We can actually harvest the patient's own bone and use that to augment deficiencies. Osteoinduction is the ability to stimulate those cells capable of formulating bone regenerative cells, like bone morphogenic proteins. And there's a lot of confusion in the market considering grafting procedures. There's a lot of products out there, including allografts, which are cadaver bone. bone from another human, xenografts, which is bone from an animal source, usually cow, sometimes horse now. And then there's synthetic materials, which are referred to as alloplastic materials. Our allograft material, there's different types. There's cortical, which is the cortex or the harder outer surface of the bone. Then there's cancellous bone, which is more the medullary porous bone. And some of our materials are mineralized and some are demineralized. And it's important that we understand that when we talk about demineralization of bone, we mean that the inorganic materials are actually removed from the graft site, leaving the organic matrix, which exposes more bone morphogenic proteins for osteoinduction. Most materials, most allografts are not necessarily osteoinductive unless we have a demineralized component to it. So just be conscious of that. And then finally, osteoconduction, which all our materials are, simply provide a structure that is created to support or scaffold bone development. So it's like stones in concrete, so to speak, and it forms a matrix. And I'm going to demonstrate the materials that we use that are certainly osteoconductive. But again, I want to leave you with the fact that whatever we place in a socket, it's going to be removed. Osteoclasts are going to invade it, and osteoblasts will lay down new bone. So no matter what we have in the site, it will be eventually removed and totally replaced by the patient's own bone, when and if we protect that allograft or alloplastic material from epithelium development. Now, some of you who are listening today may have taken grafting courses and may have attempted to do grafting procedures. You understand the importance of it, but then came back after a few months and found that the site was just mush. It wasn't really hard bone. And that's just a technique problem. And again, what I hope to demonstrate is to provide you the tools so that we can predictably grow bone 100% of the time. We use our grafting materials for ridge preservation, for socket preservation, socket grafting. And I think this is a very important part of what we do as dentists to try to maintain hard tissue, especially in the aesthetic zone. For those of you who have family members who may need dentistry, I think that it's imperative that we try to maintain adequate hard tissue in the aesthetic zone so that we can provide outstanding emergence profile to these sites. We can repair facial wall defects, and I'll demonstrate these clinically in a little bit. We can actually use our graft materials to grow a facial plate of bone predictably 100% of the time. And again, we're going to demonstrate that in just a few moments. So all of you who are listening, especially the general dentists out there, I strongly encourage you to get involved. When we talk about atraumatic extractions, what that means to me is that we are atraumatic to the hard tissue or to the bone. You know, as an implantologist in Detroit, I see so many left root tips in the jaw. And it's very frustrating for me because I have to go in there and remove these root tips that may be embedded deep into the jaw before I can place my dental implants. So removing teeth is a challenge. It's hard work. And that's why we all have so many instruments in our practices to try to remove difficult situations. But I'm going to demonstrate the technique that I use very predictably in my practice. And then at the end, Kurt Lawler from GoldenDent will provide you some information of some wonderful courses that we provide at our dental school at the University of Detroit Mercy. When we extract, we'll go through grafting techniques and protocols in preparation for dental implants. So today, let's look at it as the first day of the rest of your professional life, and let's show some clinical things. Here we have a mandibular molar that obviously has two roots, and we want to remove that tooth easily. So tooth has a root canal. It's deemed non-restorable by our endodontist, and we're going to remove this tooth. And when you look at this radiograph, I challenge all of you, how would you remove this tooth clinically in your practice tomorrow? Well, I would assume that many of you may want to remove the crown first. And how do you do that? Well, you take a burr and you section from facial to occlusal to lingual, and then take some type of elevator or luxator or tool, and you try to break it off in pieces. Usually the distal comes off first, and then you take a scaler and try to get the mesial off, and then you try to remove the tooth. Many of you would use a molar forceps, many of you would use a cow horn, and many of you would fracture the facial plate of bone and or break a root tip in these situations. So I want to demonstrate a really awesome tool that I think everyone who's listening today at the end of the program should order. They're called the WAM key. And it is just a wonderful instrument. Anything that makes my life easier, that saves my body is important to me. We talked about extractions being atraumatic to the bone, but we also want our extractions to be atraumatic to us as professionals. I'm a big believer at this time of my life that I want to save my hands, save my arms, save my back, save my eyes and my ears. So atraumatic to me is very important. So I try to make my job easier, and any tool that makes me more efficient and proficient is worth every dime. So look at this at the end of the program and see what kind of offer GoldenDent will give you with this. And finally, atraumatic to the patient. What does that mean? We all know that an extraction on a patient is challenging, it's emotional, it's hard. And here we are taking an instrument, molar forceps or a cow horn, and we're squeezing it and we're rotating it figure 8, mesial, distal, buccal, lingual. We're moving that patient's head around, and it's a traumatic experience for the patient. So I want to demonstrate a technique that we use using the physics forceps, which will eliminate that completely with your patients, where they will look you in the eye and they'll say, "You're kidding, you're done?" Wow. Now that's marketing, doctors. Those patients are thrilled. They're going to tell their family and friends what an experience. Well, let's go back to extracting this tooth. It's non-restorable. So what I'm going to do, instead of taking a burr and cutting it from facial all the way to lingual, I'm simply going to take a burr and make a small elliptical opening on the facial aspect. I'm trying to guesstimate where the occlusal table of the preparation is, and I would assume it's in the occlusal third. You know, you normally have 2 millimeters of porcelain and or metal above a preparation, so I'm guesstimating where that is, and I'm simply going to take a burr and I'm going through the porcelain, through the metal, to the central groove area of my preparation. So I'm making a very small opening. Now, why is this important? Well, number one, removing a crown takes time. Time is money. PFM, maybe not an issue, but what if this was a zirconia crown, a Bruxer crown? How are you removing that crown? Well, I guarantee you're using a fine diamond burr, and you may be going through 2 of them to remove this crown. And those diamond burrs are $19, $20 each. So you may be spending $40 removing a crown. So in this situation, I made a small elliptical opening through the facial aspect to the central groove area. And the WAM key is a series of 3 instruments. I'm taking the smallest one. I'm simply placing it into that opening and turning my wrist. There's no force involved at all. Turning that wrist will allow that crown to pop off. Now, if we were replacing this crown and not removing it, we could actually use this old crown as a temporary restoration, put a little composite or acrylic on that facial aspect or reline it, and you'd be ready to go in a matter of minutes. So again, time savings. So in this situation though, we are going to remove this tooth atraumatically. And so in a molar tooth, a mandibular molar tooth, I will section it through the furcation area. And it's very important that we understand how that is removed. I want to make sure it's sectioned all the way through the furcation area. This will provide me basically with 2 bicuspid size individual roots, which are very easy to remove. So I'm taking a 557 surgical burr, and if you can see this video here, we're looking at the plane of occlusion, and removing that, cutting the tooth in half, you can see we did not go all the way to the furcation. So I will use my digital radiographs to ensure that we cut all the way through to the furcation, providing me with two individual crowns in that situation. So here we're angling it correctly, and you can see now we have a complete sectioning where we can remove these teeth very, very easily. So again, I took my 557 surgical burr, cut all the way through. I have it in two pieces. And now I'm going to take a radiograph, ensure that I'm all the way through. And then I'm going to take my physics forceps. This is a remarkable instrument, and I'm very proud to be associated with it. It was developed by Dr. Richard Golden here in Detroit, and it's just a remarkable tool that I would not practice without. It has two components. The beak is a shovel-shaped edge, which will engage the palatal or lingual surface of a tooth 1 to 3 millimeters subgingival. The second part of the instrument is called a bumper, and you can see there's a little green silicone piece on there. And this bumper is placed as high up or down low into the vestibule as possible. The bumper is not the working end of the instrument. It is not the working end of the instrument. Rather, it is simply a center of rotation, which allows me to create tension on the palatal or lingual surface of the tooth. That tension, by simply rotating my wrist, will create energy, which will create an enzymatic release, which will break down the periodontal ligament. So what's holding a tooth in place? The periodontal ligament. So that forceps, which is very uniquely designed with a little rotation of my wrist, will allow this tooth to luxate up and out of the socket. The instrument's not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out of the socket, protecting the facial plate of bone. Then I will take a tooth delivery instrument or a forceps and remove the tooth in total. So these instruments that Kurt will discuss with you from GoldenDent at the end of the program is a series of 4 instruments: a universal lower, an upper right, upper anterior, and upper left. You need all 4 instruments, and I'm sure that GoldenDent will have a special for you today. Bumpers are disposable. I know that's a question that is often asked. But again, if I'm going to take out a lower molar tooth, my staff will bring me 1 instrument. They will bring me the universal lower physics forceps, which will allow me to remove that tooth atraumatically. Now, these are very exciting instruments. Many of you, before you remove a tooth, will take a periosteal elevator or a periotome to actually cut around the periodontal ligament with the idea it's going to loosen it. Then many of you would take a luxator of some sort and try to wiggle the tooth before you take that forceps and squeeze the heck out of it. This is a series of instruments from GoldenDent. They are periotomes that are very uniquely shaped, and a bayonet, which is the pointy instrument on the top. I love this bayonet for root tip removal. The blue coating is actually it's plasma vapor deposited, and it's strong and it's scratch resistant, and it's a very, very, very excellent set of tools that you want to also look at when you're discussing or ordering from GoldenDent at the end of the program. These are just remarkable instruments, again, that I use every day. So going back to the physics forceps, I'm going to place my beak, as I mentioned, on the lingual surface, 1 to 3 millimeters subgingival. Now, you must have a purchase point with these instruments. So if you find that you have a tooth where it's sliding, you're going to take that 557 long surgical burr and you're going to flatten the root surface. I'm not damaging bone, rather the tooth surface. I'm going to put the bumper as far down the vestibule as possible, and with simple rotation of my wrist, I am not squeezing this instrument in the least. I am not squeezing the instrument. It really isn't a forceps. It's more of a luxator. I'm going to rotate my wrist towards the shoulder, and in a matter of a few minutes, few seconds to a minute, enough energy will be created. That enzymes will be released that will allow the tooth to luxate up and out of the socket. And here you can see the demonstration of my hand. I am not squeezing the instrument. Rather, I'm just putting pressure with my thumb down towards the shoulder. This will allow the tooth to come up and out of the socket. I'll then take a tooth delivery instrument, which is a bird beak forceps, and simply remove the individual teeth very atraumatically to the patient. We'll then take a radiograph, making sure that all our roots are gone. And then we will graft, and we'll demonstrate grafting in a few minutes. In this program, and what I teach as a general dentist, are two categories of grafting procedures. One is where we have all four walls intact. The mesial, distal, lingual, or palatal, and facial wall are intact. And I'm going to call that a four-wall defect. Oftentimes, the facial plate or the buccal plate is damaged or diseased or broken during the extraction process, and I'm going to call that a three-wall defect. We can repair both of these defects very predictably and have bone growth 100% of the time with the protocol that we're going to demonstrate. There's a lot of grafting materials, as I said. Autografts are human bone, allografts are cadaver or bone from another human, xenografts are animal, and alloplastic are synthetic materials. And I like that word synthetic, because many of our patients will not accept bone from another human. And so I think it's imperative that we have choices for our patients. And one of the materials that is one of my favorites, and I think all of you at the end of the program should order this, regardless of the special they have, it's the Osteogen Plug. Osteogen Plug is a bioactive resorbable calcium apatite, and it is non-sintered, and it has the same composition as human bone. This is a material that is very inexpensive, very cost-effective for us, very simple to use, as I will demonstrate, and we don't need a membrane with it. So very, very exciting material that I think all of you. Now, I'm not going to suggest that we use it for a facial wall defect at this time. I am, but that's not what I try to teach. I want you to have predictability with this. I've done a lot of histology, and the results have been phenomenal. So when you have a four-wall defect, meaning you have a socket, a cereal bowl, so to speak, we have a cereal bowl, so to speak, we can really put mostly anything in there, and we're going to grow bone. But I would suggest we use the Osteogen Plug. It's very easy and affordable, or an allograft material. The allograft material is provided in a putty form or a particulate form, which you will wet. But whenever we're using an allograft material, we must protect that graft material from invagination of epithelium. A socket will heal from the apex towards the crest. Epithelium will grow from the crest down into the socket, and it's a race. And epithelium grows at least 10 times faster than bone. So you can appreciate why it's important to protect that graft material from soft tissue. When a facial wall is missing, I'm going to suggest that we definitely use an allograft material, and I think the literature is pretty clear on that today, and protect it with a membrane with the protocol and technique that I'm going to demonstrate in a few moments. Again, we talked about the different types of allograft material, cortical, cancellous. I prefer to use a combination cortical cancellous material. I use a mineralized product, and my particulate size is 250 to 1,000 microns. And I'm sure GoldenDent will provide this for you. And I get great predictability. There's a lot of different membranes out there. And one of my favorite membrane is a product called EpiGuide, again from GoldenDent. And this is a polylactic acid material that is high quality, high strength. It's important, and I know we can't talk about every detail, but it's important when we have a membrane that membrane protect our graft for at least 6 weeks. That allows the healing process to occur and will allow the epithelium to slow down so it's not able to go into our socket site. So I strongly recommend that you use this synthetic material. It's very high quality. If a sales rep comes to your office and says, oh, you know, that's too expensive, I have a membrane that's a lot less expensive, the question that I want you to ask that sales rep is, how long will it last? If it doesn't last at least 6 weeks, you don't want to use it because it will become unpredictable. As I said, it's 3-layered architecture. It's a polylactic acid. It's hydrophilic. It has tremendous structural integrity and allows me to have tremendous predictability. It also molds very well. It's very easy to handle, and it will be a great asset to your practice. So let's look at a case, an osteogen plug. We have a tooth that's deemed non-restorable, a molar tooth that we're going to take out. So I take my periotome from GoldenDent, and I'm simply going around the tooth structure, facial and palatal, and I'm going to take my physics forceps and see how I engaged it. The beak is placed on the palatal surface, 1 to 3 millimeters subgingival. The bumper is high up the vestibule. You can see I am not sectioning this tooth whatsoever. I'm simply rotating my wrist towards the corner of the eye. I am not squeezing. I'm actually putting a little tension with my forefinger and elevating up. And that tooth is going to, in about a minute, is going to luxate up and out of the socket. You can see how it's lifting up and out. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth. I will then take my tooth delivery instrument, and you can see we took a very difficult tooth out in a very, very short amount of time, very atraumatically to the hard tissue, very atraumatically to the doctor, and very atraumatically to the patient. The patients are amazed on how simple these procedures are. You can see the divergence of the roots, the infection that was created. And we will then use an osteogen plug. The osteogen plug is a remarkable material that's been used in Europe for a long time, and I've been using it for many years now, very, very effectively. I lecture for them, and I also do a lot of histology. It's a bioactive resorbable calcium apatite. It's not a beta tricalcium phosphate, and it's not a dense ceramic hydroxyapatite. It's bioactive and controls soft tissue invagination and forms a strong bond when bone as it resorbs. The clusters of the material are packed and intertwined and form a hydrophilic matrix that actually absorbs blood. It's radiolucent on the day of placement, but over time you can objectively take a radiograph and see how the bone turns over a period of time. We don't need a membrane with this product. The collagen filler, so to speak, contains the graft material, and it's bound so tight that it restricts migration of connective tissue through both physical and a chemical barrier. Epithelium is going to follow the path of least resistance, and it will not penetrate into this material. And the osteogen is actually, it's a calcium deficient apatite, similar to the mineral in human bone. So it's a very simple procedure, very, very cost effective, and Kurt can explain it to you in a few moments. So this is what it looks like. It looks like a collagen plug, but it is not a collagen plug. And just remember that there's a lot of confusion out there on different products, and collagen plugs are not socket preservation or grafting materials. They're normally derived from bovine dermis, but they resorb so quickly. Many of them turn to snot literally in a few days. So it's not really going to protect the graft material from invagination of epithelium. But this material is very special, and you can see I actually cut it to make it look like the root of a tooth. We cut it so we have room for the palatal, mesiofacial, and distal facial. And as I said, it provides a scaffold. It absorbs blood. We don't have to mix it with anything, and it's very, very cost effective. And within a 3 to 5 month period, you will get complete conversion of this material to bone. So it's very, very important, though, when we remove the tooth in preparation for socket preservation that we curette. We want to remove any granulation tissue from the socket. We want to remove any purple blood. We want to remove the lamina dura from the palatal aspect of that socket. So you're going to want to have sharp curettes and be aggressive in that site. You can see the large granulation tissue cyst that we removed from that site. It was a real mess. Once it's cleaned out, you can see I'm taking my osteogen plug that's been trimmed into 3 pieces, and you can see I'm slowly just placing it into the socket, and it's absorbing the blood. Absorbing the blood. And then I'm going to pack this material firmly. We're not crushing it. It's not amalgam, but I want to pack the material firmly to the crest of the ridge. Now, there's no membrane involved here, so I'll just put a couple of simple interrupted sutures. And very, very quickly, I want you to see how I'm doing the suture. I'm taking my needle, which is a reverse cutting needle, from the crest, and I'm actually penetrating through the facial tissue. Thus, I am eliminating grabbing onto the graft material. I'm going to turn the needle around and do the same thing. Go from the crest of the socket to the palatal in this situation, and simply do some cross sutures to maintain that graft material into the site. You can see it's radiolucent immediately after extraction, but over a period of time, we will see more radiolucency, and it'll start to look like the adjacent hard tissue. Here's another example. We have a tooth that is deemed non-restorable. Don't we all love posts? We have a fracture of the tooth which results in an abscess. We're going to again remove the tooth as we demonstrated. I'm using the physics forceps, engaging the palatal aspect, placing the bumper as high up the vestibule as possible, never squeezing the instrument. Rather, I'm rotating my wrist towards the corner of the eye. The tooth will luxate, and I'm taking my tooth delivery and removing the tooth from the socket. This cannot be a simpler procedure for you in your practice. The facial wall is intact. I'm going to take the plug. I'm filling it, packing it firmly to the crest of the ridge, put a couple sutures in there, and this is what it looks like immediately post-op. You can see it's still radiolucent. After about 3 months, you can see how the bone is changing over. It actually looks different. It's going to heal from the apex towards the crest, so the crest may not look quite as mature as the apical portion. I'm then able to predictively place a dental implant, torque it into position, do a flapless procedure, after which time it will heal. We take our impression, we made a custom abutment, and we make a beautiful zirconia crown that is going to be very functional for our patient. This is a very cost-effective way of doing this. For those of you who aren't involved in dental implants, I challenge you to get involved. This is a procedure that you should be doing in your practice routinely. Here's another situation, again, a non-restorable tooth. We're going to remove the tooth. Here we're using our periotome from GoldenDent and our physics forceps, removing that tooth up and out of the socket very atraumatically. We take a radiograph to ensure that we have the tooth gone. I am then doing my osteotomy site. Now, I know this is not an implant program, but with every system you use, we're taking a small burr to a bigger burr to a bigger burr, creating the osteotomy site. So here I'm going to take my osteogen plug. After I made my osteotomy preparation, I'm placing it into the socket, and I'm simply going to thread my implant directly into that graft material. Now, what that's going to do is it's going to push that graft material to all 4 sides, all 4 walls of the socket, and allow for initial stability and a great torque, initial stability, and eventual healing of the dental implant. And our CBCT shows the graft material and the socket site that we created. Another situation, this is very important. This is in the aesthetic zone where we have a tooth that's deemed non-restorable. You can see the incredibly thin facial plate of bone in the premaxilla. This is very common for us to be aggressive and to break the facial plate of bone. But using the physics forceps, I'm able to remove this tooth without damaging that facial plate of bone. We have a socket that has been created, and I'm simply going to do my osteotomy. Again, this is not an implant program, and I'd love to take time in a future date and go through my surgical procedures. But the initial stability of an implant is from the apical 2 millimeters. And so I'm specifically placing the implant in a very specific position. I'm then going to widen the osteotomy. And here again, because the facial wall is intact, I'm taking my osteogen plug, which is a $40, $50 material, placing it into the socket and threading my implant into it. You can see what we were able to accomplish. The implant is palatal to where the socket site was per my implant protocol, but you can see how the osteogen material, the graft material, is filling in that facial plate, which is going to allow me to form a nice, healthy tissue cuff, a beautiful zirconia abutment that is in fine position, and then a final Bruxer aesthetic, zirconia aesthetic final crown. It's very important that we learn to graft, especially in the aesthetic zone, in that creating interdental papilla is mandated by having interseptal bone. If we lose interseptal bone, if we damage interseptal bone, if we grind interseptal bone away, we will not get interdental papilla. Rather, we will get stunting of the interdental papilla, which will mean that our final restoration will have a broader proximal contact, which is an issue for us. So before and after, and this is all because not that I'm special, it's rather is that we use a protocol and materials that allow us to gain hard tissue. Another situation where we have very, very thin, if any, facial plate of bone. We remove the teeth atraumatically. We always curette. Now look, we have no facial bone at the apical portion. We have bone on the coronal portion, but not at the apical portion. And so what we will do in this situation is I'll take my osteogen plug and I'll flatten it. I'll do my osteotomy, and I will actually use this plug to create my facial wall at the apical portion. And I'm threading my implant in position, and you can see how that graft material has allowed me to create a facial wall. This is very predictable and just a wonderful product to use for both implants. So what happens if you're missing a wall, if you damage the buccal plate? So let's go through that. Here we have a tooth, a patient that was referred to me for removal of a non-restorable cuspid tooth. Again, we had a horizontal fracture at the post line, and you can see from the CT scan that the facial plate of bone is very thin. We may even have a dehiscence at the apical portion. So again, using the physics forceps, which is again a tool that I would never work without, I engage it on the palatal, put the bumper as high up the vestibule, never squeeze the instrument, rotate my wrist. The tooth will disengage up and out of the socket. I'm simply taking my tooth delivery instrument and removing the tooth. And you can see the curvature on the facial, which corresponds to what we saw in that CT. Now, I did a post-op CT, just again, this is for education, to prove to you that that facial wall is indeed intact. But I do have a dehiscence at the apical portion. So what I did is I made what we call an envelope flap, where whenever we're grafting, we have to We have to protect the site from invagination of epithelium, and to do that, we must extend our membrane beyond any defect. So here I'm reflecting the epithelium so that I can actually see the defect at the apical portion. I'm then going to take my EpiGuide material and place it so that it extends at least 2 millimeters beyond the apical portion of that defect. You can see it's very passive. Unfortunately, as dentists, and I'm going to include myself in that, when we first start doing grafting and membrane, we understand what we have to do, but we don't appreciate how important it is to be able to reflect the flap properly and carefully. This membrane must be placed passively. It's not something that can be forced down into the gingival tissue. So here we'll use an allograft putty material, which is graft from a cadaver. It's osteoinductive because it's demineralized, and we get a lot of quick bone replacement in this situation. So here I'm taking this putty, and I had my membrane in place, which is creating a new wall. I'm simply placing my putty into the socket, and I went ahead and I placed the implant through that, tucked my EpiGuide, my membrane, onto the palatal surface, and you can see my suture procedure from the crest towards the facial, from the crest towards the palatal. And we don't have to get primary closure with this membrane. Again, it's a high quality membrane that's going to last for several months. I just need it to last for 6 weeks. So again, if you want one high quality product, I would talk to Kurt and see what kind of package that they can put together. The post-operative CBCT illustrates the position of my implant. It was not where the socket was, rather it's palatally positioned, which allows room for abutment and final crown fabrication. The area heals, we uncover, we make our impression. Here, for those of you who may not be familiar, and I'm not sure what GoldenDent's relationship is at this point with Kettenbach, but this is a high quality German polyvinyl siloxane material that you should all look into. In that it's such high quality. They actually sell to many of the other companies that sell to you and mark it up by 30%. So it's a very cost-effective impression material. And anytime you can save money on something that you're simply going to throw away in the garbage in the future, I think is wonderful. And we're able to fabricate a final crown, which is very functional, very aesthetic, and the tissue health is wonderful. Another example where we have 2 teeth that are non-restorable. We're going to remove these teeth atraumatically as we've demonstrated. Now that looks pretty basic, doesn't it? It looks like, okay, we got the teeth out, good for you. You must take your curette and determine if there is any defects. And this is a wonderful grafting kit from GoldenDent. You should look into it. This is what I use in my practice. Again, very, very high quality, and it's all in one place. If you're going to get involved with grafting and implant placements, you must have the proper tools. And so I'm sure Kurt at the end of the program will have a special on this kit, which I truly appreciate, and something that you'll use every time you do a graft procedure. So you can see we are going to curette, and we decided that there is a facial defect. So I'm going to take an Orban knife, and I'm going to reflect that tissue, and you can see the tremendous defect that we have there. I'm also going to reflect the tissue palatally because I have to be able to passively place my membrane. Here's our particulate allograft material from GoldenDent, and I will wet it with sterile saline or sterile water. It will become a gel. High quality product. Again, 250 to 1,000 microns. Very, very high quality if you wet it. It's going to turn into a gel. And now I'm simply going to take my EpiGuide and cut it to the proper shape. We must extend this membrane beyond any defect. And so you can see I'm actually using that membrane to create a new facial wall. My implants are in position. You can see there's no facial wall around those implants whatsoever. I'm going to pack my material firmly, and I'm going to passively place the membrane across the crest and tuck it underneath the palatal tissue and suture it into position. Again, I don't need primary closure with this high quality membrane. In a matter of months, you can see we have a healthy site. We have attached gingiva. We have a facial plate of bone. We take our impression and we're able to fabricate some nice functional Bruxer crowns. Another situation where we have a non-restorable tooth, and you can see the periodontal issue that we have here, right? Again, a fracture at the post line. We're going to remove this tooth atraumatically. You can see I'm creating tension or pressure on the palatal aspect, which is resulting in some pus coming out of the facial aspect. The tooth is luxated up and out of the socket and removed. Curette, you can clearly see that we have a facial defect. So again, I'm going to take my my particulate, I'm going to wet it, creating a gel. I'm going to take my EpiGuide material and cut it to the proper shape. I'm going to take an Orban knife and reflect that tissue so I can clearly see beyond the defect. I have no problem placing my implant and growing a facial plate of bone. It's very predictable as long as you protect it. This implant is stable, but there's no facial wall. I'm going to go ahead and place my membrane beyond the defect, at least 2 millimeters. That becomes my new wall. I'm going to place my graft material, close it over, suture it. You can see I'm very consistent. You can see the defect has been filled in with our graft material, which is rather radiolucent. 1 week post-op, after the implant has a chance to integrate, you can see the nice tissue cuff and the nice facial wall. We will then fabricate a zirconia abutment and a final implant retained zirconia crown. Last case, we're almost finished here. I wanted to demonstrate a more complicated situation. You know, being from Detroit, you know, we do a lot of implants, and there's such a need for patients wanting implants. They look on the internet, they're educated, they're coming to your practices. So I challenge those of you who aren't involved in implant dentistry to really get involved. But this is a situation where half the arch was in good shape and half wasn't. So what do? We're going to remove the teeth. I fabricated a little flipper appliance. I removed the teeth atraumatically and reflected the tissue facial and lingually. I'm taking a curette, cleaning out any granulation tissue, and I immediately placed 5 dental implants. You can see that threads are exposed in the center implant. So what am I going to do? I'm simply going to take my EpiGuide, long-lasting polylactic acid membrane. I'm going to create a new wall. I'm going to repair the defect, tuck the membrane passively, and suture. The implants are going to be allowed to integrate, to allow to heal. We'll take a final impression of the implants, torque the abutments into position. This is called a smile composer. It's just an acrylic template to kind of help me establish occlusion and function. Because we have so much bone loss, we're going to use pink porcelain on the apical portion, and we're going to provide the patient with a functional implant retained bridge. This is something definitely within the realm of everybody in the audience listening today, and we have a huge group, Lauren. I'm very proud to do that. Hopefully we'll see you at some of our courses, either through the University of Detroit Mercy or our other programs. And if there's anything else that I could help you with, you can contact a GoldenDent, and they'll be happy to relay, or Lauren, and they'll be happy to relay anything to me directly. So keep it simple. I would In my practice, we have an allograft material, either a putty or particulate. I would have osteogen plugs, and I would have the EpiGuide membrane. That's all you really need to be able to provide your patients high quality, predictable results in your practice. And it's also a very, very exciting part of our profession. It's very dynamic, it's stimulating, and it's very financial rewarding. So I challenge all of you out there to get involved. So I'll let Lauren take over with Kurt, and he can talk about the specials that you may have.
Thank you, Tim. I am going to switch the screen over to Kurt. And I know, as I mentioned before, Kurt and Golden Dental have been a fantastic sponsor of these webinars. We appreciate that. Kurt also has a special offer to make tonight for everyone that's on the webinar. So we'll let Kurt take it away. And Kurt, you got the screen.
All right, Lauren, appreciate it. Thank Dr. Kosinski for another excellent presentation. There were some new cases I haven't seen in there this evening, which were great. It's always nice to see different cases and demonstration of some of the products that we offer. So GoldenDent, our slogan is practice different. I know a lot of you that are on the webinar this evening join our webinars on a regular basis, but if you're new to GoldenDent, we have the slogan of practice different because a lot of the products that we have are unconventional or unique solutions to a lot of areas of dentistry that can be frustrating for dentists, whether it's extractions or grafting or implant placement, crown removal. We really take great strides to find products that are truly unique and clinically effective. So we're a third generational dental family. These are just some fun ads that we have from the Detroit News from 1940 from Dr. Golden, where it just shows extractions were $1 at that time. So you see there in the circle, it looks like extractions and x-rays were offered for $1 back on 115 State Street here in Detroit. And we use that that family knowledge of over the years just to make sure that we have products that clinically work and are effective. We don't have a huge catalog, and the reason for that is that we really do search out and try to find products that do work. I'm going to go ahead and provide the special first. Somebody told me once before, they said, Kurt, why don't you just provide the special right away at the beginning instead of the end? And I said, fine. So I think some people want to start looking around online as I'm speaking here towards the end, or maybe during the Q&A session. But if anybody does want to take advantage of any of the products that were demonstrated this evening by Dr. Kosinski, the promotional code for a 15% off savings, which is actually very good. That's actually even better than we do at the trade shows or through any different specials we do throughout the year, whether it's an email blast or other places. This is a really good promotion, and we just offer it for a quick 24 hours based on the opportunity to save 15%. So the code is 15 golden. So it's just a numeric 15 and then GOLDEN. It should work whether you type uppercase or lowercase. But anyways, that's the code for this evening, and you can learn more at physicsforceps.com. I'll come back to that here at the end, but I just wanted to mention that. So anybody that does not already have the physics forceps, Dr. Kosinski already kind of went through this, so I'll do this quickly. But our standard series is our most popular set of instruments. This is definitely what you'd want to start out with if you do not already have the physics forceps. This set is the easiest set to use, provides the best leverage, and there's 3 upper instruments and 1 lower instrument. And these come with a 90-day trial period on them. Like I said, we come from a dental family background. We understand what junk drawers are. We really do truly want our products to work for you. And we have really long trial periods on pretty much all of our products that are not a consumable-based product. And you've got 3 full months to try them, watch the DVD, use them many times, call us with questions. We're here to support you and see if this is a good fit for your practice. But this is really the original set that was started our company in 2007, and we have not changed the designs, just some of the finishing on the instruments. And these have really been proven to work over the years. There's just a lot of really happy users. The next product here is our molar series instruments. These are more of an accessory to the instruments I just showed you. These reach further back into the mouth for hard to reach second molars or erupted third molars, the angle comes straight into the mouth, so you don't have any of the cheek restriction that you would maybe with the other set that I just showed, the standard series set. However, you do lose a little bit of your leverage with these, and they are a little bit, there's a little bit more of a learning curve with this set than the standard series. So if anybody has never used our product, I would probably take a look at the standard series at a minimum. And we also do obviously have them both packaged as a set of 6 instruments together. These are the separators. I'm not going to mention these for very long here. I think we went through it already in pretty good detail. But these are inexpensive. I mean, through the promotional tonight, I mean, these are $74 instruments. It's a pretty fair price on these. These are just a good instrument to use if you're going to start to sever the PDL or separate the tissue prior to using the physics forceps. Or I know we also just have users that actually just like to use these for the entire extraction procedure. These are a couple new instruments we've been just launched not that long ago. This is, we put our distal elevator type handle more on an instrument that we're calling the wedge. Would be another alternative to the separators that I just showed you. It's a perfect pre-step to your atraumatic extraction process. It allows you to use a little bit of leverage with the instrument where it has a sharp, thin tip, but it has a real wide handle for you to get the grip where you can push apically and kind of wedge in between the surface of the tooth you're going to extract, allowing you to loosen the tooth prior to using the physics forceps. This has been a popular instrument for us that we just launched not that long ago. Same with the reflector here. This is also, the tip of it's not too terribly unique, but it's nice with the handle where it allows you to get a good grip on the instrument. And some of the cases that were demonstrated this evening, like when you're reflecting a lot of larger areas of soft tissue, this is a nice instrument to use instead of maybe another typical type instrument that looks like this that you may use. We have a really pretty big shovel end on the end of this instrument, and it has, again, a larger elevators type handle on it, so it allows you to get a good grip and have control of the soft tissue. Osteogem plugs, we talked about this in detail. Really great product, super popular for us. I mean, with the discount, I mean, you can't go wrong. It's $42 a bullet, $212 a box this evening with the promotional code of 15 golden. You could take a look if you're interested, or if you're already using them, I guess take advantage of the specials. Bone, if you're using another bone product, our Gold Dust product's great. We have great feedback on it. I mean, if you take advantage of the promotional offer with the buy 5 and the get 1 and kind of double combo those up, I mean, our 0.5 cc is only $45, which is pretty darn fair for allograft. But it's not all about price. I mean, like I said, we clinically test our products. We make sure they're sourced from reputable bone banks. We're happy with the quality. And, we always work with doctors like Dr. Kosinski to make sure that our products work and they're good and before we launch them to the market. This is the putty. The only thing I'm going to show here is if you look at the bottom right, which is kind of unique, some doctors like how you can just pop off the black little cap and sort of dispense the putty in that manner. Or you could take off that whole large white cap there at the end and it would come out more at a time. But I just wanted to show that some people do like the ability to have the two different methods of flow with the putty. BioViva, I just have a couple more slides here, so then we'll get to the Q&A. BioViva, this is really great. Anybody using gel foam, take a look at this. This is really, it's not a graft material, but it's a hemostatic wound dressing or to control bleeding. Really a great product. I think the box of it's around $50 for 20 pieces. I know we've got a ton of users that have switched from gel foam to use this. I think if you look at what you're paying for gel foam or ask your office staff what you're paying for gel foam and compare it to $50 or the clinical use of this BioViva product, I think you'd be really shocked. And people are saving thousands a year and having great results with this product. So I do want to mention it because it is very popular for us. EpiGuide, we already went in that detail. This is our graft kit. It's this very simple graft kit. You can keep it together. You're not always looking around for different instruments. This kit's around like $400. I mean, it's not expensive. It comes with a cassette, 10 instruments, has everything in one place. So when you're ready to graft, you have everything ready to go. WAMKey, I know this wasn't really a crown removal webinar this evening, but we did mention it at the first case. So if anybody is cutting off crowns, this is a great alternative to cutting. Works great with zirconia. Has a 30-day trial period on it. The technique is really simple. It's the same type of concept as physics forceps. It's based on leverage. And as long as you follow the protocol, people do swear by this. It's been around for a long time. You can read any independent reviews on Dental Town or different sources. People do speak highly of the product. Lastly, I just want to mention real quick, Dr. Kosinski he mentioned a little bit during the webinars. We've been doing hands-on live patient programs here in Detroit for, I'm trying to think now, maybe 7 or 8 years. And you can learn more about our programs under our educational website, which is amplifydental.com. The promotional code does work for that too if you're interested in any educational courses. These are just some photos of some past classes. I really just want to show you the facility here. So day 1 is usually going to be in the classroom. We do a lot of hands-on modeling. Then we start day 2. This is the facility here at UAD. We have a course coming up next weekend already. I mean, if anybody's interested or sort of local, we do have openings still for November for some reason. Our courses typically do sell out. December's already sold out. But if anybody does want to come for November, we'd love to have you. I know we have a few openings still. This is the clinic floor. It's all live patient, so it's extractions, grafting, and in preparation for whether it's a denture or implants. It just builds the foundation of kind of what we discussed this evening, going through the protocol. But it's really a great way to do it. I mean, you get to do it on live patients. So we had a course this past weekend. I think we saw about 60 patients. It was one of our slower paced media denture programs, so we didn't have as many patients as we normally need just because we were doing full arches. But this is a great way to learn. I mean, it's live patient. I mean, how can you go wrong with learning on live patient what you learn in the classroom after the second day? So each doctor has their own operatory. They work with a partner, and that's generally how the program works. I'd be more than happy to answer any questions about that here at the end. Again, I'll leave this up, 15 golden. Very important. We only do it for 24 hours. It's a good deal. If you're going to take advantage of it, please take a look online this evening or call us tomorrow. We'd be more than happy to talk to you in detail about any of our products. And that's it. Sorry if I talked too long. Lauren, I'll turn it back to you guys for Q&A, and I'll just leave this up on the screen.
Okay, don't go far. Actually, the first 2 questions are for you, Kurt. So we do have a few of my fellow Canadian citizens on tonight. Are any of the Golden Dental stuff available in Canada?
Yeah, sure. Yeah, I know we do ship to Canada. So yeah, absolutely. I don't know what products they're talking about, but yeah, we do ship to Canada quite often. Not that it matters that we're close, but if you remember, I guess Detroit's right across from our.
They can swim across the lake to come get them.
Yeah, that's right. Pretty much where I'm sitting right now, I'm actually north of Canada here in Grosse Pointe, Michigan. So yeah, no, not that it matters, but yes, we do ship to Canada.
Okay. And do any of the courses cover sinus grafting?
No, we didn't, not right now. No, we keep it. Again, we focus more like on the GP market. I mean, we're trying to keep a simple protocol or a recipe, kind of like Dr. Kosinski mentioned. We really don't get into that currently. We do the types of cases that were shown this evening, whether it's just missing a facial wall or 3 and 4 wall defects. We focus on that, and we try to keep it. I don't want to say simple by any means, but we try to keep a protocol based on those types of procedures, and we do not get into like sinus lifts or anything like that in our courses.
Got it. Okay, thank you. Tim, you ready to go for some questions here?
Sure, of course, Lauren.
Okay, so I'm going to try to combine some of these because, as I said, we're not going to get to every one of them. What's the difference between the Osteogen strip and the plug, and can the strip be used under a buccal flap to bulk up the bone at a second stage surgery?
It's a great question, a question I get all the time. It's the same material, but I'm going to recommend that the newest users not use the strip as a membrane per se. I am doing research on it. I've had the tremendous results when all 4 walls are intact, Lauren, when the facial wall is there, and get great bone ingrowth. I've had some results when I've used the strip as a membrane. but I think it's important that I think that the most important thing of the program today is that you have to feel comfortable reflecting the tissue. You have to see where the defect is, and you have to put whatever material you are in a membrane beyond the defect. And so sometimes we have a tendency to do short. We try to take shortcuts, and then we don't get the predictability that we want. And I'm not sure if I'm being really clear there, but just placing something in there and hoping that it works isn't good enough for me. I want to know that it works, if that makes any sense.
Yep, it does. For people that are using the forceps, when they do have the occasional buccal wall fracture, what is typically the number one issue or problem if they're still having those occasional fractures when they're using the forceps?
Again, very astute question. And that's why I showed some of the CT. Lauren, sometimes we just can't help it. The facial plate of bone can be so thin that, it's like an eggshell almost. And I showed a couple of those cases. But I think it's imperative that we not rush the instrument. We allow energy to build up, meaning enzyme to build up to break the periodontal ligament, and that we never squeeze the instrument. It's not intended to be squeezed. And so our muscle memory has to change because we're used to taking a forceps and squeezing.
Okay. If you have a 3-wall defect, is it best to, with an infection, is it best to wait until all the infection's been resolved?
Great question. No. I think when we take a tooth out, we're removing the source of the infection. You're going to curette any granulation, any purple blood. Red blood is good. And Lauren, I guess the best analogy that I can make is if any of you out there have had a hangnail, where you're at a park or something and you can't walk, it hurts so bad, and you go home and you soak your foot and you clip that nail, and within 5 minutes you forgot that you even had a problem. The body's an amazing thing. I have no problems grafting in a site that was infected. I just don't put implants in immediately in those sites.
Got it. In one of the cases, you showed the bumper being placed over the mental frame, and any concerns with that or any problems with that?
Again, the bumper is simply a fulcrum, a center of rotation. We're not squeezing. It's not holding the facial plate of bone. It's not pushing on the tissue whatsoever. It's simply a center of rotation.
So if somebody does occasionally see some ulcers that develop where the bumper was, are they just not putting it in correctly? They're putting too much pressure?
Too much pressure, squeezing. Yep.
Okay, perfect. Any extra precautions you use for long-rooted maxillary canines with thin facial plates using the physics forceps?
Yeah, that's another great question. So that's where I would use the separators that Kurt and I demonstrated, where I will try to separate the facial bone from the root surface as much as I can, and sometimes that will help.
Okay. How do you present the treatment plans to the patient, especially if you don't know ahead of time if you're going to be needing the grafts or the membranes post-extraction?
Okay, again, great questions, Lauren. I'm very impressed. So in my practice, if I'm taking a tooth out, I'm grafting it without exception, and unless it's in an anesthetic area where I would never consider putting an implant in. And what I explain to the patient is when we take a tooth out, we're going to create a socket or hole, and that socket or hole is shaped like an egg. If I'm going to place an implant, the implant is round, and so I have to fill the gap created with basically a caulking material, and I'll explain the different types of materials. I will tell my patients, I know there's a cost to this, but if we don't preserve that site, the bone is going to shrink down and in or up and in, or the sinus is going to collapse, which may make future implant placement more difficult or more expensive, in that we'd have to build the bone back up. So I think the point that I make is you have to decide as a clinician what is a fair price for you to charge for this procedure. You're charging for the extraction normally. But for those of you who are not currently grafting, you have to decide, well, what's the fair cost? Well, if you're only paying $40 for the material and it's only taking you 5 minutes and you're using a $12 suture to close it over, it doesn't have to be a prohibitively expensive procedure for your patients.
Yep.
Because you're preparing it for a future site.
Okay. If you have gone ahead and grafted a socket with the oxygen plug, approximately how long do you typically wait before placing the implant for the bone to have formed in there?
Again, a great question. And what the advantage we have is with the material is that we can determine bone turnover objectively with our digital radiographs. So remember I said that bone is going to heal from the apex towards the crest. So we're going to get more mature bone at the apex than towards the crest. But again, I also said we get initial stability of our implants from the apical portion. So that's an advantage to us. So it really, Lauren, it really depends on how big the hole is. If it's that one case I showed, the molar tooth with the big infection, that's going to take a while to fill in. That may take 6 months. But routinely, I'll take a radiograph in 3 months and determine the healing properties of the patient. But usually between 3 and 4 months is when I would place an implant.
Okay. Another question about what was the impression material that you used in the lecture?
It was called Kettenbach, Kettenbach. You can talk to Kurt about that, or you can go to kettenbach.com. They sell direct. It's the highest quality material. They actually manufacture the material. It's the last impression material sold directly to dentists, so they don't have the major markup. You'll save thousands of dollars by using it.
You showed a case where, in the very beginning, where you showed sectioning the mandibular molar. Do you always do that before using the physics forceps?
Again, as dentists, we get comfortable with our procedures, and so the answer to that is if the roots are divergent at all, then it's just as easy for me to take and section it and take the individual roots out as if they were single rooted by cuspid teeth. I know that's very predictable for me.
Okay. So kind of a two-part question here. How long does the graft material last before you have to place an implant, and how quickly is it resorbed?
That's a great question. The literature will say you have about a year. It takes about a year for bone to mature completely, and after that time, if it's not being stimulated, it'll start to resorb. So after a year, you can predict that we'll start seeing shrinkage again. And how long is that process going to take? It all depends on the patient.
Okay. So an example, tooth number 5, implant exposed because of a flipper. How would you typically graft something like that?
I guess we're talking about bone loss around the implant. And it's very, very challenging to grow bone around an implant. That's really not going to work very well long term. The theory of treating the ailing, failing implant has come and gone a lot of times in my career, and there isn't really a real predictable way of doing that. And that's not what we really demonstrated today. That's a difficult situation to treat.
Okay. Let's see. What about if someone extracts, say, an upper bi and they found that there's a perforation to the sinus at the apex? How would you handle a case like that?
So sinuses are a little bit scary to the general practitioner, but the body's an amazing thing and it'll heal. So if we did get a perforation, number one, I would either put a membrane and allograft, or you can put an osteogen plug in there and suture it over. Tell the patient that they may have stuffiness on that side of the nose, and we don't want them to blow their nose and put a lot of pressure there. So I would tell them, if you do feel you're stuffy on that side, just go to the drugstore and get some nasal spray. It doesn't matter which one you get. Tell them that if you did perforate, they may have a bloody nose. I would tell them to sleep with an extra pillow, elevate their head, and maybe even put a towel on their pillow. So, if they do get a little bleeding during the night, that they don't mess up their sheets.
Okay. I want to get to a few more questions, and we're going to wrap it up in a couple of minutes here. Can pressure from the particular graft material harm the inferior alveolar nerve if there's intimate contact between the roots of, say, number 31 and the nerve?
Well, that's a great question. I'm not really sure. But as I said in the program, you're placing the material firmly. It's not amalgam. Okay, you're not crushing it. So it's kind of free forming to the socket. So compress it firmly, but don't overdo it. It's not amalgam.
Okay. If someone did have an implant placed and the healing button became exposed, do you typically just leave it alone before the second stage surgery, or would you typically try to do something about that?
If the healing abutment becomes exposed, you mean comes out? I'm not sure the question.
Well, if you can actually see it, I guess, so that if you're all of a sudden, you have a.
I would leave it. Yeah, I wouldn't be concerned with that. Yeah.
I don't know, and obviously, I don't know if you're comfortable discussing fees, but what's the typical fees that you see for a GP to place an osteogen plug as a simple socket preservation procedure?
Well, that's another really, really important question. When we were in dental school, probably Lauren, you too, we didn't get very much business training, right? But they told us hey, you charge 5 times your lab bill, for a procedure. So I think that depending on, if you use an allograft material in a membrane, you may have $150, $200 worth of material there, as opposed to an osteogen plug where I think Kurt said it was $42. So what you charge, you have to feel comfortable with, and I look at it as preparing a site for future potential revenue for me. So I would say on an average, from doctors in my courses, I would say anywhere between $300 and $500 for a graft, because you do have time, you do have suturing, you do have post-operative, you want to remove the sutures, and so there's valuable time in there. But I don't think that is a prohibitive amount of money in the whole scope of what we're doing.
I agree. Okay, well, we're going to wrap it up. So any closing comments before we call it a night?
Lauren, I truly appreciate it. What a big crowd, and I know we talk fast, but we wanted to cover a lot of material in a very short amount of time, and hopefully we'll see you at one of our future courses. And Lauren, I'll see you soon, and God bless.
Thank you, Tim, and appreciate it. I want to thank Tim for being so generous with his time. We always get hundreds and hundreds of people that come to listen to Tim. He knows his stuff. He's really very approachable, as you all can tell from the webinar. And really, I learn something every new that I watch a webinar, and I've done probably at least a dozen with him, if not more, over the last couple of years. Special thanks also to Kurt from Golden Dental. I use this expression a lot when I talk about them. They say what they mean, and they mean what they say. And as it relates to that special, when Kurt said it's good for 24 hours, that means if you call him on Thursday morning, don't expect to take advantage of the special. But, as he had mentioned, everything's got money back guarantee. We have dozens and dozens of our clients who use physics Forceps and a lot of the other stuff that Golden Dental provides, and we've never heard a negative word about them, which is one of the reasons we're so happy to have them sponsor. So we thank Kurt, we thank Tim, we thank all of you, because we know your time is valuable. Hopefully you got something out of it. We do these webinars on a regular basis, and you will all be notified of upcoming webinars. So thank you all for joining us tonight, and we'll see you all on future webinars. Good night, everyone.
Good night.